They're live.
Students, 30 plus, we start.
So, good evening, respected faculties, delegates, as well as our fellow students. It's a great pleasure to once again welcome you for our Master Bedside Clinics in Nephrology. So, this will be our 12th episode. We're very happy to have our course directors, Dr. Vijay Kher, as well as Dr. P.P. Varma ji on board. We'll be more than happy to ask them to welcome the examiners for the day as well as discussant, and accordingly take it forward from here. Over to you, Dr. Varma ji.
Thank you very much. I think thanks Microlab for this symposium and teaching class. We are in the 12th episode of Master Bedside Clinics in Nephrology. And today we are discussing an important topic, that's the infection-related glomerulonephritis. That is relatively a newer topic. And today we have got two very learned and respected academicians, Professor Sanjiv Saxena, who was in faculty with AIMS initially, and then he's heading the nephrology department at PSRI in Delhi, and Professor Santosh Varughese, again, a very learned and respected teacher. He's a HOD and professor in nephrology at Christian Medical College, Vellore. The student for today is Dr. Anamika Das. She's a second-year DM resident at CMC Vellore only. And mind you, before I proceed, we also have an expert on the topic, Professor Gopal Krishnan. We will also request him for his comments in the end. To introduce the topic, I hand over to Professor Kher, and he will start the proceedings for today. Professor Kher, sir.
Good evening, ladies and gentlemen. It's a pleasure again to welcome you to this session of Master Bedside Clinics in Nephrology. And today the topic is especially very, very relevant to the Indian conditions of infection-related glomerulonephritis. Infections remain one of the commonest causes of morbidity and mortality in patients with kidney disease. And there is an ISN Frontiers meeting from 22nd to 25th also in Delhi. And this is a Frontiers meeting, which is usually one or two meetings held once in a year across the world. And this time, this is going to be held, and this is again related to infections and the kidney, and the topics very well. So I will request, before I ask Anamika to present the case, I request everyone to try and register and attend this conference. I'm sure they're going to benefit immensely from the experts coming from world over, actually. And so I'm sure this is going to be an extremely interesting conference. So I would request people to come and register and join. There is still time. This is 1 week ahead. So I would request everybody. So the topic is infection-related infections. And I think there is an amount of work done from CMC Vellore and Dr. From the CMC, from Madras Medical Institute, and Dr. Gopal Krishnan is published also recently on these topics. So this is something which is dear to us, and I'm sure if you have a patient available in the wards during the exams, I'm sure you're going to get that patient. So very, very important for the students to solve. So Anamika is all yours. So you can, and I'm sure
I think I just wanted to say Dr. Santosh and Saxena also published a paper in C. Jason on this topic only. Recently.
Yeah. Okay. Anamika, all yours.
Okay, sir. A very good evening to
Yes.
respected panelists, my dear colleagues and fellow physicians who have joined in today. So I'm here to present a clinical case on IRGN. Firstly, my patient is a 37-year-old Hindu housewife hailing from Vellore, who presented to us in CMC in August 2022 with the chief complaints of sudden onset of swelling of feet and facial puffiness for 3 days prior to presentation. Along with that, she also mentioned having decreased urine output for the past 3 days. Coming to the history of presenting illness, the patient was... Yes, sir.
Can you stop here?
Yes, sir.
Okay, now tell us from your presenting complaints, what do you think is a syndromic diagnosis that you would like to put your patient in? You know, your chief complaints are chief complaints because they tell you a fair bit about what is the disease that the patient is suffering from, and therefore, based on that, you would go ahead and take your presenting history. Right, you have several of your points in the future history and in the past would depend on what you think from the presenting complaints.
So from my presenting complaint alone, I would feel that it is a case of an acute nephritic syndrome, because the patient presents with rapid onset of swelling of feet and facial puffiness. Along with that, she also mentions a decreased urine output. So definitely there is a glomerular pathology involved. Since it is very much acute and associated with oliguria, I would like to say it's an acute nephritic syndrome.
Okay. So why do you think that it can't be an acute interstitial nephritis?
Sir, her predominant complaint is also facial puffiness and swelling of feet, which I think will more point towards the glomerular pathology.
Okay. So in your opinion, most patients with the acute interstitial nephritis will come with good output and no edema. Is that so?
Definitely they may have, sir, but that may be secondary to the decrease in urine output, secondary to the oliguria. Usually I don't feel that it will be presenting simultaneously.
Okay. Now tell us, you said this is a 37-year-old lady. Is that
Yes.
right?
Yes, sir.
Okay. What is the value of, and she hails from Vellore itself, is it?
Yes, sir.
Okay. So now what is the value of knowing the age of the patient?
Sir, because the age group is very important, sir, because certain diseases are restricted or at least commonly found in certain age groups.
Tell us some diseases which are found in particular age groups.
Sir, if
renal diseases, of course.
Yes, sir. So if we think firstly of a pediatric age group,
Yes.
a pediatric age group, then we may think about an acute post-streptococcal glomerulonephritis may be there. IgA vasculitis may be there. That is more common in the pediatric age group. If
Very
we
nice.
think about the adolescents, they may have commonly they may be having C3 glomerulonephritis may be more common than in an adult or a middle-aged person.
Right.
A young female presenting with these complaints, we may think of a lupus nephritis or
Very good.
or
Yeah.
an IgA nephropathy.
And if
Whereas,
this was 80 years old?
if 80 years old, I would think of maybe a vasculitis, ANCA vasculitis.
Right. So, do you know, the age is important. It's not just that we say this is 27-year-old or 30-year-old or 37 years old. It has its own value, right? So you must, and tell us some regional kidney diseases that you know of, because you see, why do we say this patient is from North India or this part of the world? Why? Can you tell us some geographically limited diseases which are predominantly seen in some geographies?
Sir,
Not really with these chief complaints, but
yeah.
in general, yes.
Sir, certain nephropathies, especially chronic interstitial nephropathies, may be seen like in the tropical areas,
Like?
especially if there are endemic nephropathies in the South Indian region, in Andhra Pradesh also is there.
Do you know of some kidney disease named after regions? Because they were seen there only.
Like the Balkan and endemic
Very nice.
nephropathy.
Balkan nephropathy. So what was that due to?
That was due to aristolochic acid.
Okay, so Balkan is one. What else? Any other disease which is related to a region?
So,
why I'm asking is not related to IRGN, but as a student, you are supposed to, if we are going to focus only on IRGN, the whole thing, then we can hear the story and say, well, this is IRGN, that's it. No?
Yes, sir.
So, have you heard of Mati Bay disease?
Yes, sir.
What was that?
That was due to mercury.
Very nice. Okay, tell us some diseases which in India are seen in one particular region of the country. Do you see stone disease in South India? Renal stone disease?
Yes, sir.
You see? Or are they all from the north? They come to you?
We see from South Indian patients also.
Right. Okay. What is the stone belt of India?
Not very sure, sir.
Okay. So the entire sub-Himalayan region is the stone belt, so to say. Okay.
Okay, sir.
Yes. So because there are a lot of kidney stones in these areas. Some other renal diseases that you see in particular parts of the country? Some diseases which you only see in rural areas?
Like rural areas, mostly we get chronic interstitial nephritis, which may be due to working in high temperature areas.
What acute renal failure happens in people who are engaged in farming? Paddy cultivation.
More in south.
Leptospira, have you heard?
Yes, sir.
How does leptospira enter the body?
So it is through contamination with consumption or contact with water which is contaminated with rat urine.
Yes,
Usually,
you think it's by drinking that water, or is somewhere some other way it enters?
No, it's not always drinking. Even through contact, it can.
Okay, so you aren't very sure about it, is it?
Yes, sir.
Okay. So what type of malaria do you see in South India?
So we are getting mostly vivax.
Yes.
Some amount of falciparum is there, but relatively rare.
Okay. So you see renal disease in vivax or no?
More commonly seen in falciparum, sir.
So a sudden onset acute renal failure, more often with falciparum, correct?
Yes, sir.
Okay, go ahead. This is just to tell you, don't restrict yourself. Should have a full
Yes,
perspective, right? There is some point in asking what is the age, because then you know what diseases. You're not going to think of benign prostatic hypertrophy in a 27-year-old male. You will not think of myeloma in a 27-year-old male, right? So that's the reason that why do you say that she comes from this place? You should know why, right? There are diseases which are specific to certain areas, right?
Yes, sir.
Okay, go ahead.
So, coming to my history of presenting illness, the patient was apparently well until 3 days back when she noticed sudden onset of swelling of her bilateral lower limbs, which was associated with facial puffiness, which was more in the morning. And it has been progressive over the last 3 days, involving her abdomen as well as her upper limbs as well. She also simultaneously noticed that her markedly reduced urine output for the last 3 days as well. And on admission, she was passing less than 500 ml urine per day. She mentioned that around 1 week prior to admission, she had a history of trauma to her right ankle, during which she secured a cut over the area, and it was followed by pus discharge. She consulted a local doctor for the same, and she received an injection which was given intramuscularly, but the details or the prescription was not available with her. She did not have any history of fever preceding or during the illness. She did not have any cough or sore throat preceding or during the illness. She did not notice any urinary discoloration. She did not have any flank pain or painful micturition. There was no history of any toxin or intake or any alternative medicine intake during or preceding the illness. And there was no history of any joint pains, rash, or oral ulcers or hair fall. That is all about the presenting illness.
Coming to Anamika, you said there is no discoloration. What discoloration were you specifically looking for in this patient?
Sir, specifically, I asked if she passed any reddish or any dark red colored urine, which may be suggestive of, which may be seen in an acute nephritic syndrome. Like
is it dark red urine or is it called something else?
Cola colored urine.
Yes. So your examiner must know that you are well versed with the lingua that goes along with renal diseases, right? Of course, yes. It's classically cola colored, no?
Yes, sir.
Right. So did you ask that specifically?
Yes, sir.
Okay. You should have mentioned this, that there was no history of hematuria or cola colored urine, right? Fever is correct. Cough and sore throat is correct. Dysuria, okay. Go ahead.
Coming to the past history, the patient had first presented to us in 2014 with the at that point of time she had a complaint of swelling of feet, lower limbs and headache for 3 months, and she had no known comorbidities. On evaluation at that point of time, she was diagnosed with hypertension, and she had shown microscopic hematuria with deranged renal function and with a creatinine of 2.4 milligram per deciliter and subnephrotic range proteinuria of 1.4 grams in 24 hours. At that point of time, her ANA was weak positive, dsDNA was negative, complement C3 was low, 61.7, and C4 was 6.96, which was also low. Her ASO titers were elevated, more than 1740 international units per ml, and anti-DNB was normal. ANCA was negative. In view of the clinical features and the investigation, she underwent a renal biopsy that time, which had shown a proliferative and sclerosing glomerulonephritis picture with cellular to fibrocellular crescents in 12 out of 20 glomeruli, and 3 of them were globally sclerosed. And IF had shown granular mesangial as well as capillary wall deposits of IgG, which was 2+, predominantly C3, which was 3+, C1q and C4 were negative. So at that point of time, we kept a clinical diagnosis of IRGN, infectious related glomerulonephritis, and she was started on oral steroids at 2 mg per kg on alternate days, which was continued for 6 weeks at the same dose and then tapered over the next 6 weeks to stop it. She attained remission with that and achieved a nadir creatinine of 1.19 milligram per deciliter in 2014 itself. And she remained on regular follow-up till March 2022 when her creatinine was 1.09 milligram per deciliter. She was, however, having subnephrotic range proteinuria, which was expected due to the severe glomerular disease she had at that point of time. She had proteinuria in the range of 500 to 700 milligrams, and she was continued on ARB, which she had stopped 1 week before current presentation. Coming to the family history, there was no history of similar illness in the family. She follows a mixed diet. She had, prior to her illness, bowel and bladder habits were regular, and there were no addictions. That's all about the history, sir. And now I'll present the clinical examination. The patient was conscious, cooperative, well-oriented to time, place, and person. She has an average Indian build and has a decubitus of choice. Her blood pressure was 160 by 80. Pulse rate was 87 per minute. Respiratory rate was 14 per minute, and she was afebrile. She was pale on examination. There was no icterus, no cyanosis, no clubbing, no lymphadenopathy. She had pedal edema extending up to her knees. She also had an ulcer present over the right ankle on the lateral aspect, which was around 3 into 3 centimeter. There was no visible pus discharge or bleeding from the ulcer, and a well-formed scab was visible over the ulcer. Coming to the systemic examination, cardiovascular system-wise, S1 and S2 were heard well. There were no added sounds or murmurs. She had normal bilateral vesicular breath sounds, no added sounds. Her abdomen was soft, non-tender. There was no organomegaly, and bowel sounds were present. And she did not have any focal neurological deficits. So at this point of time, after my examination, after my history and clinical examination.
Tell me, Anamika, just pause here for a minute.
Yes, sir.
Will you sum up your history in, say, 4 lines?
My patient is a 37-year-old female who is a who has a past history of IRGN in 2014 and had attained remission after a course of oral steroids at that point of time, came with the chief complaint of sudden onset swelling of her bilateral lower limbs and facial puffiness, along with decreased urine output over the last 3 days, which was following an injury to her left ankle, for which she had undergone treatment elsewhere. She did not have any any fever or hematuria along with the current presentation.
And what was the last follow-up that she had done for the previous IRGN that she had?
She last followed up in March 2022, sir.
March 22. Oh,
yes.
That was pretty recent. Okay.
Yes.
Okay. Before we go to your differential diagnosis, in the, you told us the biopsy report of the first IRGN episode that she had.
Yes, sir.
She must be then about 27 years or maybe 25 years old.
Yes, sir.
Right?
Yes,
so,
sir.
Just go to that biopsy slide. Yes. Okay. So you think it's common to have 3 out of say 20 glomeruli sclerosed at the age of 24?
No, sir. It is not very a common finding, but at that point of time, she was already symptomatic for 3 months when she had presented in 2014.
Very good.
So probably the diagnosis was late.
Yes. And yet you think your patient responded so beautifully to steroids, no?
Yes, sir.
Her GFR would be what, 70 ml or so? No? With
yes,
the
sir.
creatinine 1.01, you said, I think.
Yes, sir. 1.09 on last follow-up. When she had first presented in 2014, that time her creatinine was 2.45. After steroids, her creatinine had come down to 1.19, and she was maintaining in around that range, 1.1, 1.2, 1.09. In that range, she was maintaining.
Right. So why do you think that she was IRGN then and was not, say, lupus nephritis?
Sir, at that point of time as well, she had, though she had low ANA positive, but she did not have any symptoms of any other symptoms of connective tissue disease at that point of time also. Like she did not have any joint pain, any rashes, any features of pleuritis, any skin facial rash. There was no other systemic involvement apart from renal involvement. Also, C3 was low, which improved after the course of steroids on
So
her
what
follow-up.
is C3 in lupus? Is it high, low, normal?
No, it is low, sir.
Okay. So that doesn't make your...
If we also see the biopsy report, C1 was negative. The
right.
biopsy report, so that also is a pointer that we may not be dealing with lupus nephritis, though her age group was typical of lupus.
Yes. So my only thing was, you can also say that, she had a high ASLO, and is that right?
Yes, so she had a high ASLO titer.
Yeah, that also points towards post-streptococcal glomerulonephritis, right? So
Yes.
will you like to say that probably, it wasn't IRGN, it was probably lupus nephritis, and we gave steroids and she responded beautifully to it. And this ASLO business is, by the way.
Sir,
what is there in the IF which will tell you that this is more likely to be IRGN than SLE or vice versa?
Sir, usually in IF, in case of IRGN, we'll get predominantly C3, or at least C3 will be co-dominant with IgG.
Right.
Whereas lupus will get, typically we should get a full house pattern. That is
so she didn't have the full house, is it?
No, sir.
IgG and C3 predominant.
Yes, sir.
Okay. Dr. Santosh, were you happy with the diagnosis of IRGN that time?
So I don't believe I was looking after this patient, but I think the general feeling was it was an IRGN because of the C3,
okay.
But C4 also was low, but then the ASLO was high.
Right. Okay. If Dr. Santosh agrees, then Anamika, you and I can't debate on it. Okay. So you go ahead.
So after my history and clinical examination, I came to the following differential diagnosis. Firstly, I kept IRGN as a differential diagnosis. My points in favor of the diagnosis where one is her acute presentation. Along with that, she had history of recent trauma, along with pus discharge, which are relatively healed by the time she came to us. So a concomitant infection source was there. And though recurrence of IRGN is very rare, but we kept that as a differential diagnosis to follow up with investigations. Another differential was due to the acute presentation. We kept ANCA vasculitis as one of the differentials. Though points in favor were the acute presentation along with oliguria, but points in against the diagnosis of ANCA vasculitis was her age, which was not fitting into the criteria. Also, she did not have any symptoms of hematemesis or any cough or any lung involvement. So that was also kept in mind. IgA nephropathy was also kept in mind. One thing is she had been following up for the last several years. Though IgA was not present in her first biopsy, IgA deposits were not there, but she continued to have subnephrotic range proteinuria in the range of 500 mg. So there's a possibility that she may have an underlying IgA nephropathy over the years, and which has gone into a crescentic transformation. So we kept that also in mind. due to the rapidity of the onset of symptoms. Another diagnosis was C3 glomerulonephritis, which we kept in mind. Though the age group was not fitting in, but based on our previous biopsies report, which was C3 predominant, we kept that also in as one of our differentials. However, point against that was on her follow-up in between, in 2015 itself, her complement levels had normalized. Also, due to her age, we kept lupus nephritis as a differential, but it was, she did not, as in her previous presentation, current presentation also, she did not have any systemic features of lupus or SLE. There were no new onset rashes, joint pain, or any other systemic involvement suggestive of a connective tissue disease. So with that in mind, we went ahead with relevant
Anamika, just pause here.
Yes, sir.
So you see, you yourself contradicted yourself and you said IRGN recurrences are very rare. They're not common, at least.
Yes,
so, and yet you have kept it as the first diagnosis.
So because her clinical presentation is along with her...
clinical presentation is like a glomerulonephritis.
Yes, sir.
Right? Or was she given some drugs for that wound?
Yes.
And the pus discharge that has resulted in acute interstitial nephritis?
Yes, sir, that is also possible, but I felt it was more of a glomerular pathology because she came with hypertension. Along with that, she had pedal edema as well as
hypertension was just there, which can be due to volume overload, right? It wasn't terrible hypertension that you would be worried about. No?
Yes, sir. So
definitely
you
haven't even considered this. And at the same time, you say IRGN, the second episodes are uncommon or rare.
Yes, sir. So, yes, I also thought of that, but since my...
since you know the biopsy, that doesn't... if she walks into me, I would think that, probably one of the drugs that he has received has probably played the trick, and now she is into an acute renal insufficiency because of, I'm sure they must have given her some painkiller, some antibiotic, mostly, for skin, people will get one of these penicillin group of antibiotics.
Yes,
and I'm sure you know that they are very, very likely to cause AIN. AIN is often very, very slippery in making a diagnosis. Where you don't suspect, you get in your biopsy AIN, right?
Yes.
So AIN is clinically, because we are fascinated by glomerulonephritis, especially the vasculitis, right? So we tend to think in those lines, but AIN is not too far-fetched from this. And I would still say, would you like to revisit lupus nephritis, which is your last diagnosis on this slide? Of course, I don't have the good fortune of investigation so far, and neither do I know the biopsy report, right? So I would have thought that did she have lupus nephritis, which was treated and she responded, melted away, like, although unusual, with just steroids, and the type of histology she had, she virtually melted, and the kidney became almost okay. Right? And has she relapsed again because she must be now off steroids for a long time? No?
Yes, sir, but it is like...
And the infection and the
between two relapses without any immunosuppression.
Which is lupus known to have more relapses, or you think IRGN tends to have more relapses? Lupus, right? So we've all seen so much, despite being treated with what have you, cyclophosphamide, this, that, they come back with, so of course, I think we can go ahead, but these are my thoughts without knowing anything. I have no idea as to what your investigations have shown up and what the histology shows, but I would be tempted to not keep IRGN as the number one diagnosis. Your wound and the thing came together, I think. Is it right?
Yes, sir. Right.
Which is like, somebody being given a drug and the patient develops acute renal failure. He has developed AKI secondary to probably the medication that you said about Ayurvedic drugs. Well, Ayurvedic drugs we all ask, but don't we know many of our drugs play havoc with the kidney? No?
Yes.
So it's just, food for thought for you. I'm sure
Yes,
you're
sir.
right. And your diagnosis will hold true in the end. But that's what I think as a clinician you should analyze, right?
Yes.
Okay. So now go ahead. Dr. Santosh, anything you would like to add?
No, Anamika, when you said, actually, sir, she asked me if she should put AIN as a diagnosis. So I said, the discussion is IRGN. So actually, I dissuaded her. So I must confess that
Okay.
I had a part to play in her not putting AIN as a diagnosis. She did ask me. Anamika, why did you ask for fever during or preceding the onset of edema? Why did you ask that history?
So because sir, if this is a fever is a sign of any infection. That is one thing. If I think of an IRGN, I should ask for history of fever preceding, even 1 month or 2 months preceding the presentation, to get a temporal association with that. That's why I asked for fever in the patient.
Supposing the fever was during the edema versus fever was 2 weeks before the edema, or the fever is along with it, or just a week before, does that make a difference to your? Does it make a difference to in any way? Does it make a difference to the prognosis or diagnosis?
Yes, sir. In the prognosis, it will make a difference because suppose that patient is a case of IRGN. If the IRGN is concomitant with the fever, with the infection, then we should aggressively treat the infection first. Immunosuppression will not be our choice of treatment. Whereas if the infection is preceding the glomerulonephritis, then our aim should be supportive management as well as immunosuppression. So our management will differ, and prognosis also is poorer in case of concomitant infection with GN.
Yeah. So do you know how any way we can classify with terms of timelines to and the onset of the GN? Any way you can classify these things? The GN.
Yes, so we can classify as para-infectious, peri-infectious, or post-infectious.
What are the timelines?
Onset will be at the same time, that is 0 days, whereas peri-infectious will be 5 to 7 days after the onset of the infection or symptoms of infection, and post-infection will be at 10 to 14 days or later.
So of these, which is the best? Which is the worst prognosis? Which is the best prognosis?
Para-infectious have the worst prognosis, whereas post-infectious have the best prognosis.
And the organisms also, does it make is there any difference between the lot, the organisms?
Yes, organisms. Over years, actually, the organisms have changed, but para-infectious mostly is seen with staphylococcus infections, and mostly it's more seen in methicillin-resistant Staph aureus infections.
Para-infectious, you can get to even with a lot of gram-negative bacilli infections you can get. So yes, that's something also which is kind of new. You said the urine output was dropped to less than 500 ml per day.
Yes.
Why did you say 500 ml? Why didn't you say 1 liter or 400 ml or 700 ml? Why did you say 500 ml?
Sir, the patient was not able to exactly quantify the urine in terms of, if I have to say oliguric, I have to say 400 ml, but the patient in her language or her estimation, she was not able to specify it correctly.
What the patient said is that 500 ml important for us as nephrologists. Is the volume, like we ask patients every day, how much urine do you pass, but is that volume important for us, or is just for us to write down in our notes?
No, so definitely the volume is very important to assess whether the patient is oliguric or anuric, or whether he has.
Why this 500 ml? I think magic about this value, 500 ml.
No, I'm not sure, sir.
What volume of
Osmolality?
Yes. What is the maximum concentration ability of the kidney, and what is the maximal osmotic load that person has to excrete? That will tell you the answer to what Dr. Varughese is asking you.
Sir, up to 1300 milliosmoles per kg is the maximum concentrating ability.
And what is the osmotic load every day?
It is 700 to 900.
It is 10 milliequivalents per 10 millimole per kg body weight, roughly. So you are producing approximately 600 milliosmole of solutes based.
Yes.
So that is what, even if the urine is maximally concentrated to a osmolality of 1200, even then you will require 500 ml to throw the osmotic load. That is why you are saying that it is a 500 ml
Okay.
oliguria. So that is a minimum amount of urine which will be required to throw the daily osmotic load.
Yes, sir.
Anamika, one point, although diagnosis, as Santosh said, is not the strongest point of discussion for these master bedside clinics, but since a lot of discussion on this, would you consider that this patient has an underlying chronic kidney disease and the current infection is nothing but an acute event on top of an underlying chronic kidney disease?
Sir,
what you
sir, definitely the patient, as I mentioned previously, has been having subnephrotic range proteinuria since her last episode in 2014. So definitely she has chronic kidney disease if we quantify as in terms of proteinuria. But it is definitely possible that it may be an acute event over that underlying chronic kidney disease. That is definitely possible.
If you look at it from that aspect, then probably what Dr. Saxena is saying may make more relevance, that there may be an acute interstitial nephritis on top of an underlying chronic kidney disease, or it may be just an infection producing a hemodynamic alterations. Although your possibilities for the current illness, I agree the differential diagnosis is okay as such. But I would have, but Santosh has already said that he didn't let you because the diagnosis is not the strongest. We usually discuss the topic much more than the diagnostic methodology or the criteria and other aspects in this bedside. You go ahead now because the time is slipping, so we need to discuss the acute IRGN as well. And how do we manage such patients? Go ahead.
Yes, sir. So coming now to the investigations which we did for the patient presented to us on 9th August. So at that on that point of time, she had a creatinine of 3.9 milligrams per deciliter. Her urine RE showed RBCs of 60 per high power field, WBC of 100 per high power field. Blood was 3+ and protein was 4+. She did a 24-hour urine protein the next day, which showed proteinuria of 3.4 milligram. But her urine output was only 140 ml, which was submitted. In that, the UP by UC was 12. Her urine culture did not show any significant growth. Her creatinine increased on 12 to 4.48 milligram per deciliter and then gradually started coming down. So coming to the other investigations, her albumin was 2.8 gram per deciliter. ANA was negative, ANCA was negative, C3, C4 were low. C3 was less than 18.3 and C4 was 9.5 milligram per deciliter, which is just below our labs cutoff, which is 10 milligram per deciliter. ultrasound of the kidney showed normal sized kidneys with raised echogenicity, and a renal vein Doppler was done, which did not show any evidence of renal vein thrombosis. So these were the relevant investigations done for the patient.
Okay,
Now,
go ahead.
So after combining the investigations as well my clinical history, I enlisted the points in favor and points against the respective differential diagnosis which I had put forward previously. So firstly, IRGN, like I mentioned, points in favor was the clinical presentation, history of skin infection which was preceding the illness, and low C3 as well. However, points against were recurrence, which is very uncommon, and also the patient had nephrotic range proteinuria. So these are relatively uncommon. Then coming to my next differential, which I had presented, which was ANCA vasculitis. Only point in favor was the clinical presentation. Otherwise, all points, laboratory investigations wise, there were no significant points. ANCA was negative. The patient had nephrotic range proteinuria. C3 was low. Age group was unlikely, and she did not have any other evidence of systemic vasculitis. IgA nephropathy, again, the age group was in favor of the diagnosis, and clinical presentation, though not very common, but crescentric IgA nephropathy can present in this manner. She also had subnephrotic range proteinuria, which I mentioned, which may suggest presence of an underlying IgN. But points against were IgA nephropathy, relapses or sudden onset of crescentric IgA nephropathy is usually precipitated by respiratory infections, of which she did not have any signs or symptoms. And also C3 was low. Coming to C3 glomerulonephritis, points in favor were the low C3 nephrotic range proteinuria, but points against were age group and the previous episode in which she had a similar presentation, it had a good response to steroids. Coming to lupus nephritis, again, age group and gender was in favor of the diagnosis, and also the clinical presentation, which may be seen in lupus nephritis class 4. However, there were no other features of connective tissue disease, and lupus serology was negative. So we went ahead with a renal biopsy. So the renal biopsy showed, though it was a post-glomerular renal biopsy, which showed only 7 glomeruli, but it showed diffuse sclerosing and focal proliferative as well as exudative glomerulonephritis, and it had a segmental cellular crescent in one of the glomerulus. Along with that, she had mild tubulointerstitial scarring. However, there was no viable glomerulus available for evaluation by immunofluorescence microscopy. So we could not make a diagnosis based on IF. However,
what in your Anamika, what in the light microscopy will not IF tell you that this is more in favor of IRGN?
Sir, presence of an exudative glomerulonephritis is typical of IRGN. If we see neutrophils,
it's very tough. Neutrophils being more, I think that's probably the only clue. Otherwise, the light microscopy really doesn't tell you which from which, IgA, whether it is
yes,
IRGN or it is lupus. All these present in a similar fashion, light microscopically, very little. And did your pathologist report a lot of neutrophils in the exudative lesions?
Yes, sir.
He did. Okay.
Yes. So there were some chronic changes were also there, sir. She had a mild tubulointerstitial scarring. So 15 to 20.
Anamika, if this biopsy you have seen, and again, IF is not available because
yes,
it's a scanty sample, but the pathologist tells you that there is a lot of wire loop lesions that you're seeing. Okay, the same presentation, sclerosing, proliferative, exudative.
Yeah.
And you have wire loop lesions, what will be your differential diagnosis at that point?
So wild loop lesions also can be seen in lupus nephritis.
Okay, that's one differential. One more.
Even in IRGN as well as cryoglobulinar vasculitis, we can get wild loop lesions.
In IRGN, it is typically not seen. Typically, you see it in you see where are the deposits typically seen more in IRGN, in which part of the glomerulus? Like, is it mesangial, is subendothelial, subepithelial, intramembranous? Where are the deposits most seen in
Subepithelial, sir.
Subepithelial is more common, although you do see subendothelial as well. Whereas you get a lot of subendothelial deposits in what condition do you get? You can get a lot of subendothelial deposits in the context of what we're discussing. Infection-related GN, any type that you can see a lot of subendothelial deposits.
So if it is a staphylococcal associated IRGN, then we can get both subepithelial as well as subendothelial.
And the IF would be?
IF would be the deposits of IgA will be there along with C3 and IgG.
So it's a IgA dominant IRGN. You'll get a lot of subendothelial deposits. It can look like, it can even resemble cryo with high intracapillary hyaline pseudothrombi loop lesions. You can get that. Histologically, how would you differentiate a plain IgA nephropathy with worsening of renal function and an IgA dominant IRGN on biopsy? A regular IgA nephropathy versus an IgA dominant IRGN on biopsy.
Sir, this is definitely a diagnostic dilemma, but still a presence of a diffuse proliferative glomerulitis, glomerulonephritis is more in favor of IRGN as compared to IgA nephropathy, which may have just mesangial or endocapillaris hypercellularity.
Another thing, Dr. Varughese, what about C3 deposits? You know, C3 outnumbering IgA would probably point towards more IRGN than IgA per se.
Yes. So please go ahead, sir. Ask, sir. Dr. Saxena, please go ahead and ask.
No, go ahead.
No, sir. Please
Anamika, please go ahead.
Okay, sir. So based on this, we kept a differential. We treated her as a recurrent IRGN. We managed her conservatively with IV diuretics, antihypertensives, fluid and salt restriction, which she symptomatically improved. And she was started on steroids at 2 mg per kg alternate day. She's gradually showing biochemical improvement and symptomatic improvement, and she was discharged from the hospital. On her last follow-up, creatinine had come down to 2.8 milligram per deciliter, and she was passing around more than 2 liters of urine per day. So, mostly that is my presentation. I've just enlisted the approach we followed in management of the case. First, we identified the clinical syndrome, and then we kept our list of differential diagnosis, and we proceeded with specific investigations. We ruled out renal vein thrombosis in view of oliguria and hypoalbuminemia. And we proceeded with a renal biopsy, and we started a treatment with steroids, with which she's gradually improving.
Okay. So in IRGN, where do you think is the role of steroids? In what type of IRGN? And specifically related to what infections and the timing would you recommend starting steroids immediately, or would you delay in some patients, wait for spontaneous resolution?
Yes, sir. Actually, most of the studies have shown that there is not much difference between giving steroids and not giving steroids. The ultimate renal outcome is more or less the same. However, if I have to choose a patient who comes with crescentic GN in the form of IRGN, I would prefer to give steroids to such a patient. Another thing is, if a patient has a concomitant infection, active ongoing infection, my focus will be first to treat the infection, especially if the patient is an elderly or a diabetic or is immunocompromised. My focus would be to treat the infection and not give immunosuppression to the patient. The renal failure, I try to manage conservatively.
So are you trying to say crescentic, or are you trying to say somebody who presents as a rapidly progressive renal failure? RCGN, I would say.
Sir, if the patient comes with a typical history of post-streptococcal glomerulonephritis, that is maybe after 2 to 4 weeks of a respiratory tract infection or a skin infection, he has developed a GN. He falls in the he's in the age group of he's in the younger age group, the 3 to 15 years of age group, which is the typical age for PSGN. Then I would prefer to wait for spontaneous recovery, because the overall outcome is very good in such patients. Most of the patients, if clinically we are sure, would not even require a renal biopsy. We can manage conservatively. However, if the patient presents in an atypical age group, also the patient has on renal biopsy crescentic features, then I would prefer to go ahead with steroids.
So in this patient, how long did you wait, or did you start immediately after getting the biopsy report?
We started immediately after getting the biopsy report, sir.
And what made you decide on that?
So because one thing is she was showing worsening of renal function. Creatinine was going up. Also, she had crescents in the renal biopsy. Though it was a post-glomerular biopsy, she had one cellular crescent. So we decided to go ahead with steroids.
But crescent was only one
Yes,
out of 7.
And that
Yes,
too a very partial crescent, if I am not mistaken.
Yes, sir. It was a segmental crescent.
Segmental, yes.
Yeah, the question put by Professor Sanjiv is, what is the justification? Because it's a teaching class.
Yes, sir.
Tomorrow you are getting a similar case. Will you start steroids immediately? Patient has come with 14%, 15% crescents, which is a common finding. You find a bulk of patients with IRGN will have crescents, less than 20% crescent, like this patient. Should you start steroids immediately? First, you mentioned yourself that steroids do not have a definite role. Whatever available data is there, that does not support the use of steroids.
Yes,
People
sir.
have used steroids. I think you also in the first case used steroids.
Yes, sir.
But in the second case, your point, your justification. Should you have waited? You are giving antibiotics. Should you have waited, or was it right to start steroids straight away?
So when the patient presented to us, she actually did not have any active infection. So we did not give her any antibiotics. The wound which I talked about had already healed. So we did not give the patient any antibiotic. We were not in, and as she was having worsening trend of renal function, so we decided to go ahead with steroids to prevent further decline in renal function. And she was not having any active infection at that point of time.
How would you react to this statement that, you know, she would have probably done as well without steroids as she has done now with the steroids?
Definitely, sir, there is a possibility.
Okay. Dr. Santosh, what in your opinion made you people give her steroids from the beginning? Because, you know, the students would like to know what went into the minds of the decision makers to not wait and give steroids.
Yeah, I think the fact that it's little unusual that it happened the second time round, and there was already a lag period before she had the biopsy, and for want of to try and do as much as possible and reassess in a few weeks' time. I think that's what went behind the giving the steroids. Naturally, we understand that except in crescentic situations, steroids is probably not warranted. So I agree.
Okay, and if suppose the same case, if you didn't decide to give steroids, Dr. Santosh, how long would you have waited, or would you have waited for her to actually reach a creatinine that required a dialysis, or how would you approach such a patient who has IRGN, creatinine of about 3-4 that she has come to you?
I think so. The IRGN either resolves to spontaneous resolution, or spontaneous resolution to partial normalcy, or some parts sclerosis, and there's the kidneys become sclerosed. That's why probably the biopsy had a lot of chronicity on the first biopsy itself. There was some sclerosis because of the thing. So in those who do not respond, there is segmental sclerosis, there is increase in proteinuria, and gradual worsening of renal function. That's the natural history of the disease. I don't think that intervening with steroids at that point may do. Sometimes there is a lot of compulsion from the patient, as well as the situation of the recurrence, which I think through everybody, and because she's already a lag period had happened. So giving a trial for a few weeks, like we do sometimes for AINs, we give for a few weeks and see if there's a response. If there isn't, we stop it off, taper and stop it off.
Okay.
So Anamika, can I ask one question to Anamika? Anamika, why did you emphasize on giving ARBs for this patient? Anything you want to say? Is it advisable, not advisable? And did you continue ARBs on this patient? If so, why? If not, why not?
Sir, ARB can be given in IRGN if the renal function is stable. So if the renal function is not stable, usually we should not start the patient on ARB, sorry, to prevent further renal injury. But otherwise, for ARB may have a good beneficial effect if the renal function of the patient is stable. But in this, initially in this patient, the patient was having an increasing trend of creatinine. So we did not start immediately on ARB. Also, the patient previously, in view of subnephrotic range proteinuria, she was already on ARB, which she had herself stopped 1 week before the presentation.
So are you saying the previous ARB was a good thing for her IRGN? I'm talking about the first episode of IRGN when she was given ARBs. Do you think it's a good thing or a bad thing, ARBs? So
it is a good thing. Typical PSGN does not require ARBs, but with the as the current understanding of IRGN has been changing, and association with para-infectious and peri-infectious GN has also evolved. So ARBs are definitely playing a more important role. Otherwise, typically ARBs were not advised.
So the indirect question from audience is, if a person is already on ARBs, like the present person, if a person develops acute renal failure, should we stop or not? Question 1. Question 2, if you are stopping, for how long? And then should we resume? When you should resume? First question, should we stop or not?
Sir, in case of acute renal failure, definitely we should withhold the ARB. And we should restart it only when the renal function has stabilized. That will depend on the serial follow-up of the patient.
Second question from the audience is that you said the patient had 24-hour urinary protein of 3.5 gram, 3472 milligram per 140 ml. The urine output is only 140 ml. How do you interpret this?
So we interpreted it, since the urine output was so low, we interpreted it using the urine protein by creatinine ratio at that point of time. And not only that, once her urine output improved, we also had repeated as 24-hour urine protein. Once her output improved to more than 1 liter, that time she had an 24-hour urine protein of 3.8 grams in 1.2 liter urine output. So for that, since she was oliguric at that point of time, we had to rely on the urine protein by creatinine ratio.
I'll request the examiners to give their opinion. The interpretation that many times we get patients who have got totally anuric or oliguric with urine output of 100, 200 ml. And we measure the proteinuria is 3 gram, 4 gram. Should we interpret it that way? I don't know.
Dr. Santosh, what do you say? With
Sir,
140 ml.
So I would say that I would be unhappy with the sample with the volume less than 500 ml. That's where I think the urine protein by creatinine ratio helps us. But it just means that there is a lot of proteinuria, which we may not be able to sufficiently quantify. The other thing is, I remember the textbook of Massey used to say that if there is patients, especially got macroscopic hematuria, that the frank blood in the urine increases the proteinuria, and then that also becomes difficult to quantify as being proteinuria per se, and not secondary to the contamination with the hematuria.
Correct. I think so. It's not really too much. Anyway, the whoever has asked the question, the point of the fact is that this proteinuria is not going to alter your management. You're not making a diagnosis of glomerulonephritis based on this proteinuria, right? So there are other features in the urine which tell you. So Dr. Santosh, if I sum up correctly, in IRGN, it's best to wait for some time, see that there is no sepsis left, and if there is no sepsis, then if the patient is having progressive renal insufficiency, there may be a role of steroids. It's not that they must be immunosuppressed. Is that right, to sum up?
Yes, I would agree, sir. Even in somebody who's got crescentic GN with the endocarditis related IRGN, the goals of care is to treat the infection completely, even with somebody who's got a massive amount of crescents, like 50-80% of crescents. We still treat the infection completely, then consider immunosuppression. I agree, sir.
Right. So the message is not that you should start steroids immediately, but maybe a good idea. But I agree, in practicality, many times we do use. So in fact, Dr. Gopalakrishnan has just messaged that the role of steroid is not definite, and that is what I intended to underline. I think we must take his opinion. Yes,
we will take his opinion, because what the summarizing the cases are, the first case, what happened in 2014 to the lady was probably post streptococcal glomerulonephritis, because that is the time ASO was pretty high.
Yes, sir.
Yeah, so that was probably post streptococcal glomerulonephritis with crescents. And that was treated with steroid because the crescents were more than 50%. I think 12 out of 20 were crescents, which is very unusual. But if it is occurring now, was that also IRGN? That is also IRGN, because the students should know even post streptococcal glomerulonephritis is simple IRGN only. That is a way of form of IRGN, and that is the time steroids were given that time. Now, the unusual points that time was also more than 50% steroids, a good response for the more than 50% crescents, and good response to steroids. The second episode, again, you have nephrotic proteinuria in IRGN, which is also rare, which is also in a minority of patients. And you said C3 is also low, C4 is also low. That is also, again, in a minority of patients. You will have C3 low. That is pretty common. You can have, there are some conditions where you can have C4 low, but to have both C3, C4 low is again little unusual. We will take opinion from Professor Gopalakrishnan also, his expert comments, and what does he say about the two presentation, different presentation of this in the same patient, and about the role of steroid. Professor Gopalakrishnan, please.
Good evening, sir. First of all, my apologies for joining late. I was held up in an emergency, so I could not really get the grasp of the complete the sequence of clinical events that has happened over a period of time. I concur with your kind of intrigue. It's a really intriguing clinical picture. In IRGN, by and large, we don't get hypocomplementemia C4 because C4, a low C4 denotes classical pathway activation. So whenever we come across a low C4, of course, it doesn't mean that it should not happen. It is so complex. It is not a single pathogenesis. It's a kind of a variegated pathomechanism. That's what we have understood about IRGN. But before concluding it as an IRGN, we have to vigorously rule out lupus, ANA negative lupus. And we don't have the immunofluorescence picture. Unfortunately, the pathologist could have tried a reprocessing of the tissue submitted for light microscopy and tried for looking up for the presence of immune reactants. That is number one. So ANA negative lupus is still a possibility, which is there for in about 5% of the patients due to the prozone phenomenon and so on. And the response to steroids in the initial phase, and probably it was an exacerbation, and then patient was in a long period of remission or quiescent. And now again, there is a flare because exudation, there is a presence of neutrophils in very few glomerulopathies we do come across. One is IRG and the other one is lupus. And yet another condition where there is associated low C4 is cryo. But here the clinical picture doesn't fit into the cryoglobulonemic glomerulonephritis, and in cryoglobulonephritis, the response, the improvement in the kidney function will not happen so predictably and so precise. So that's it. That's for academic interest, I'm saying that, low C4. So before proceeding this, before concluding this as IRGN, I would like to rule out lupus. Occurrence of second episode of IRGN, we have come across, but it is not common. That's number one. And number two, as such, I mean, as you all discussed, we will be tempted to start on steroids whenever we come across a patient with IRGN, particularly the rising creatinine and presence of even in few glomeruli and so on. But in our experience, and recently we have published in Kidney International Reports, I don't know whether you have come across that. It is the first ever randomized controlled trial on glucocorticoids and infection-related glomerulonephritis. Of course, there was a limitation. The sample size was not really powered to answer this tricky question, but the conclusion was steroid was not effective. And a non-randomized observational study, which we have published a few years ago, exclusively in the so-called crescentic IRGN, again, steroid didn't help at all. We were wondering why steroid is not helping. Because we have been taught that IRGN is a prototypical example of immune complex glomerulonephritis. By and large, any immune complex glomerulonephritis, your response to steroid has to be good. Now, the answer for lack of efficacy of steroids in IRGN, in the recent IRGNs, is that even though we call it as IRGN, the typical PSGN, post-streptococcal GN, which we have been seeing in the ester years, is an entirely different disease. And what we do see as IRGN in adults, particularly even in elderly, in our series, the most common pathology in the elderly geriatric population is IRGN. So this disease is entirely different. It is no longer an immune complex glomerulonephritis. Here C3 is low because there is activation of the complement. There is predominantly role of a complement, a plasmin-mediated damage to the kidney, and that results in the activation of injurious cascades, including complement and infiltration of cells. It invites cells into the tissue and so on. That is why the immunofluorescence pattern, about 30 years ago in our own series, it used to be a kind of presence of immunoglobulins as well as C3. There are few instances where we have even come across a full house IRGN. But now, the Sami-Nazar criteria, that is the criteria that is applied and utilized across the globe, it clearly says that C3 alone or C3 dominance. So there has been a switch in the understanding of the pathophysiology of the so-called infection-associated GN. It is no longer an immune complex. It is a complement-mediated disease. That is why there is a dismal response to steroids. Thank you, sir.
Thank you very much. Professor Kher, sir. I think
Anamika, one question. How long will you give steroids and what is your expectation of this creatinine? You said she is responding, creatinine has come down to 2.8. What do you expect? This creatinine will touch the same way as happened in the first episode, 1.09, or you think it is not going to be the same? And if you are going to wait till then, how long will you continue steroids? What will be your cutoff for discontinuing, or would you continue for 6 months or so if the creatinine doesn't come down?
No, sir. Actually, we are following a protocol. We are giving steroids at 2 mg per kg alternate day for 6 weeks, after which we taper rapidly over the next 6 weeks. So my expectation is that she will not achieve her baseline creatinine, sir. Because she already has a bit of chronic damages. Also, she already had sclerosed glomeruli as well in her previous biopsy as well. So I do not expect her to reach her normal creatinine, but I definitely expect it to improve further.
Okay, given what Dr. Gopal Kishan talked,
yes,
and
sir.
to get another patient, similar patient, so what would you do? You would give steroids or not give steroids? I'm putting you into on the spot, difficult decision. So I thought, with this knowledge, what will you do? You will give steroids. You pass. Now you are independent. There is no pressure from your consultants. So you are independent making a decision. So what will you do? Will you give steroids or not give steroids?
Sir, if the clinical presentation is such that
same, no if.
Okay.
The same page.
Just know that not required. All right. Okay.
If you want to, Anamika, if you want to pass your DM, you must say, I will follow what Dr. Santosh teaches me and I will not change. But see what Dr. Gopala Krishnan said, exactly what I said. You know,
yes.
Lupus is still, and would you consider, say, if she doesn't settle to, or maybe even if she settles, would you consider doing a second biopsy and trying to do an IF?
Yes.
Because, even I said, this first was lupus, then she was in remission, again, now this is a flare. Of course, unfortunately, IF was not there. So, an important point that Dr. Gopala Krishnan also made, C3 more than IgA is IRGN with IgA dominance. C3 has to be more, the predominant this thing. Of course, pure C3 leads you to C3 glomerulopathy. That is a different chapter then. And they don't respond to steroids. So that doesn't work here.
Yeah, but many patients with C3 glomerulopathy, which we label because many of our people don't get electron microscopy done, and immunofluorescence may be lacking in some of these patients, except that C3 is seen, or many of them are labeled. They may be IRGN are labeled as C3 glomerulonephritis. This is probably not necessarily right. I'm sure Dr. Gopal Kishan would agree with that some of these patients with C3 GN probably maybe IRGN as well.
And just a corollary, if Dr. Gopal is also a comment on IgA dominant, because we are not talking that it is a complement prominent disease. What about IgA dominant IRGN? Is Dr. Gopal around?
Yes, sir. Yes, sir.
Yeah. What about a comment on IgA dominant? Because if we say it is predominantly a complement mediated disease.
Exactly.
What about IgA dominant?
Yeah, even though classically in academia, we consider IgA dominant IRGN as a different phenotype or a variant of IRGN. Now, with more and more of emerging evidence is compelling us to consider that as an entirely different disease. There, we know the mechanism of IgA dominant IRGN, it is a super antigen, involvement of super antigen, particularly elaborated by Staphylococcus, which does not follow the conventional pathology of antigen processing and antigen presentation to the T cells and so on. Like a rogue antigen, it behaves and it causes massive activation of the cells. That is why any disease that is mediated by this super antigen, like staphylococcal scarlet skin syndrome and T and 10, toxic epidermal necrolysis, all that has got a very poor prognosis. The same goes well with IgA dominant IRGN. Whatever you do, the prognosis is very poor. Here, why there is presence of IgA? There is a massive activation of the immune system, elaboration of many cytokines, and one such cytokine is causing this stimulation of the plasma cells which secrete IgA. They're kind of a switch. And there are some people who believe that there are some similarities between IgA nephropathy and IgA dominant IRGN and so on, but it is an entirely different pathomechanism. There also C3, there is activation of complement is there. In addition to that, some specific cytokines resulting in class switch and activation of IgA producing cells, and that comes into the picture. But in the published literature, again, IgA dominant IRGN, there is no response to steroids.
Now, just the last question from Anamika. What is the prognosis of IRGN in general? Because what you are talking here, that creatinine became 2.8 or something. What is the prognosis in general?
Sir, in general, sir, if it is a PSGN, there is a very good chance of recovery. Only 3 to 5% may go ahead with proceed to chronic kidney disease. However, since this is an atypical age group and we are seeing more of IRGN in elderly, so in these patients, even up to like 40 to 50% of patients may not achieve the baseline creatinine and may have some residual.
The prognosis is not very good. So you have a vast number of patients, close to anything from 30 to 50%, who may be left with some residual damage. There were a couple of hands, Dr. UK Sharma, and if there is any question from them last minute, they can put the question. Otherwise, we ask comments from experts first, examiners. Any last minute comments from examiners? Professor Santosh, please.
Yeah, no, nothing from me. I think it's been a good presentation overall. And our questions asked were quite relevant for the wider audience of who are listening. And I'm sure that they will have benefited from today's discussions. I'm happy to be here. Thank you for inviting me.
Professor Sanjiv Saxena.
I think excellent presentation. I will give her 7.5 out of 10. Very good.
That's creditable, Anamika. That's very nice. And he has passed you with distinction. That's wonderful. Professor Kher, sir, any last minute comments, sir?
You know, I can say that when Sanjiv is there, then there is not much that one can say. He's asked all the relevant questions that need to be asked by an expert examiner like him. And I feel that I think it's been wonderful presentation as well. And I think Anamika did extremely well to all the questions. And I think she was well versed with the discussion. And I thank everybody. Yes, it's been a very good learning. And I would thank Dr. Gopal Kishan for his wise words, as well as the amount of knowledge that he knows about this condition. He has been very much interested in this, and I think it's been great being part of this.
Thank you so much, sir.
I think we thank everyone, and wonderful. I think again a master class. Professor Sanjiv Saxena put absolutely practical points what need to be asked in the exam. And thank you, Professor from Vellore also. I think all academic questions, what is desired. Thank you very much, Anamika, and all the persons, and Professor Gopal Krishnan also. Thank you very much, Microlab, for this session.
Thank you.
Bye-bye.
Thank you. Thank you.
Thank you, sir.
Thank you. Good night. Thank you very much.
Very good, Anamika. Well done.
Thank you, sir. Thank you very much, sir.
10% Anamika. Congratulations. Good. Thank you, sir, for your complimentary words to her as well. Thank you, sir.
Welcome. Welcome.
Okay, sir. Good night.